So ARF according to site of lesion, we classify this according to the site of lesion. So lesion may be pre-renal, renal or post-renal. As we all know, pre-renal is related to perfusion. So perfusion of kidney is hampered in any way, then there are chances of development of acute renal failure or AKI we call it. Post-renal also when kidney is okay, but when urine outflow is obstructed, any obstruction in the outflow of the urine after making urine in the kidney will come to pelvis of the kidney and to ureter and then to urethra or in bladder. Obstruction, significant obstruction anywhere in the course, it will lead to development of AKI or acute renal failure, or when kidney itself is at fault. So, when kidney structure is divided into three, that is vascular, that will include the glomeruli, and there is interstitium and there is tubule part where urine is collected. So all you know this acute kidney failure definition when there is rise of creatinine by 0.3 milligram within 48 hours. आज आपने किसी पेशेंट का आईसीयू में किया, चाहे इट 0.6 ही हो उसका क्रिएटिनिन, और 2 दिन बाद 48 आवर्स बाद 0.3 और बढ़ गया उसका, और 0.9 दिखने में एक में लुक लाइक ए नॉर्मल रेंज ओनली, बट यू शुड बी अलर्ट, यू शुड रिमेन अलर्ट के साथ तो AF में ARF में जा रहा है पेशेंट. इफ दिस ओलिगुरिया when the urine output within 24 hours is less than 500 ml or 25 ml per hour, तो लगातार 4 घंटे तक less than 25 ml आ रहा हो, again this is to be labeled as a acute renal failure. So sometimes it may be non-olivuric, तो पेशेंट का क्रिएटिनिन बढ़ा हुआ, यूरिया बढ़ा हुआ, बट उसके आउटपुट अच्छा रहा, 1.5 लीटर 2 लीटर 2.5 लीटर, still urea creatinine is high, so still we have to label it as a ARF only. So according to we described it, we will see that this is still a AKI or rifle criteria, last time we took it already. So pre-renal again we say when the kidney is not at fault but the vessels which are supplying blood to the kidney, they are at fault, then there will be development of AKI. So if hypovolemia due to any cause, the patient is not able to take the fluid, say patient has gone to desert, he doesn't have water, or some place where there is nobody providing water to him or her, then there is chances that patient will go into dehydration and that patient will go into ARF. So you have the bleeding areas go due to any cause anywhere in the body, bleeding हो गया, डायरिया हो गया, वोमिटिंग हो गई, lack of access to the water, then patient may go into acute renal failure. Hypotension again due to the cardiac function are at fault, acute MI हो गया, severe cardiac failure हो गया due to structural heart disease like rheumatic heart disease, और there is जैसे माइकल स्टेनोसिस हो गया, हुक्म हो गया, या सीवियर CCF हो गया किसी भी कारण से, डायलेटेड हार्ट हो गया ड्यू टू पोस्ट रेडिएशन थेरेपी, there may be dilatation of heart and weakness of the heart muscle, so it can lead to ARF. Loss of autoregulation, again patient का BP you may find it is normal, but urea creatinine is high, no other cause you find, but when you take history, they may tell you that he or she is taking either any kind of NSAIDs, non-steroidal anti-inflammatory drugs, if they are taking, particularly when patient is dehydrated. So patient coming in dehydration, and they are put on, so pain abdomen हो रहा था, You didn't started fluid for 2-3 hours, but you start giving voltaren, Voveran, so-called diclofenac sodium. Patient will go into acute renal failure. अब patient कहीं जाते हैं clinics पर कई बार दिखाने. No, we don't want any infusion, but they are having fever or pain abdomen. They are given injection diethylamine like things. Then patient will go into ARF. So this may be the cause only, but you should remember that. Similarly, RAS blocker, that is renin-angiotensin aldosterone blockers, like either ACE inhibitor or ARB, that is angiotensin receptor blocker, like telmisartan or valsartan. These drugs we will discuss, we will see how they induce. So abdominal compartment syndrome. Suddenly the increase in the volume of the intraperitoneal cavity due to trauma, there is hemorrhage, spleen rupture हो गया उसका, and patient goes into abdominal compartment, tense हो गया उसका abdomen, and that is rapidly. So it will compress the kidney vessels as well as kidney, and function of the kidney will be hampered, and they may go into ARF. Renal artery stenosis, again perfusion of the kidneys blocked due to macrovascular obstruction. This may be congenital usually, rarely in later ages due to severe atherosclerosis. Patient may go into renal artery stenosis, acute renal failure. With similar reasons, heart failure and hepatic cirrhosis. We will see there how it affects. So post-renal we will take first because smaller one better to understand about this. So there is after when kidney has already made the urine, but there is no outlet. There is no free flow to the urine outflow. So patient क्या तो पहले इसमें large stones पहले bilaterally and bilateral ureteric obstruction हो due to stones again, or if there is a bladder neck tumor हो, stone हो bladder में, large small calculi also within the urinary bladder which is obstructing the outflow, urethral opening की जगह फंस जाएगा, or itself stone into the urethra itself. So chronically it will lead to, after few weeks to few months, patient may go into AKI. Intensity alveoli knows the tubular causes, vascular causes, interstitial causes, we will see just now. So prerenal azotemia. So here the kidney is okay, but vessels supplying this, they may be at fault, or fluid present or blood content inside the vessel, it is less. So cause hypovolemia due to any cause, or low cardiac output, or disordered vasodilatation in case of hepatic cirrhosis. History of severe volume loss due to diarrhea, decreased fluid intake, or orthostatic hypotension. In an examination, you find patient is having dryness of mouth as well as tongue. Mucous membrane is dry. There is poor skin turgor, and you can lift the skin. If you pull the skin of the abdomen or arm, it will come up. It will not again gain its shape for a few seconds. So turgor you have to see in such patient. कोई diarrhea का patient है, suddenly you have to look into it. Particularly kids, they are more sensitive. Immediately abdominal skin को pinch करिए ऊपर से and leave it. See how fast it regains its original structure. If it takes time, there is wrinkles, then take it granted patient is dehydrated. So orthostatic hypotension. Patients who are okay when lying on the bed, but they are unable to go to bathroom. They may tell you that साहब मेरे को एकदम चक्कर आ जाते हैं, यूरिन भी नहीं आ रहा सुबह से, और जाने की इच्छा करता हूँ लेकिन मैं गिर जाता हूँ पलंग पे. Then suspect about orthostatic hypotension. How we define it? Patient का supine position में 110 आ रहा BP, but on sitting or getting up straight, his BP is falling. If BP is falling systolic by 20 millimeter and diastolic by 10 millimeter. In ICU also we are seeing the CVP. तो CVP अगर उसका 8 से ज़्यादा है, that means patient is overhydrated already. We have to restrict the fluid. But it is less than 8, then we have to look for the fluid status. Well, this the fluid status is poor, and he needs more of the fluid. So according to CVP, we should remember this thing also. Patient need fluid or not in ICU. So in low cardiac output, again there is drop in effective circulating volume despite increased body fluids. Patient के CHF हो रहा है, सारा सूझ रहा है patient. There is edema of feet, there is bilateral pleural effusion, and few patients you may find even the ascitic fluid also. So increase in the body fluid is there. In moderately severe cardiac failure, congestive heart failure. So, but there is not much fluid in the vessels because heart is not pumping well. So effective circulation is poor due to cardiac failure. So what there will be, patient's sympathetic and neurohormonal factors are stimulated. So RAS is activated. We will see in the next figure. So it will stimulate and cause sodium retention and ADH secretion, that is antidiuretic. उसको सेंस करेगा कि ये तो वॉल्यूम कम है. The flow is less, the body will sense, as kidney will sense it is, there is less amount of fluid in the body, so it will secrete aldosterone, it will stimulate the kidney, the suprarenal region, then aldosterone will be secreted from there. It will retain the sodium as well as fluid along with it. So again there is vicious cycle. All the other fluid retain hota, but effective volume is not there. In these cases, acute renal failure, urea is a part of osmotic maintaining salt. आप इसकी कैलकुलेशन में जाएंगे, ऑस्मोलैलिटी कैसे, तो उसमें यूरिया का फिगर आएगा. Urea is calculated as well as glucose is calculated for osmolality. So when the body sense there is less of fluid into the in the circulation, it will cause more of retention of urea. Creatinine will be excreted normally because it is now part of osmolality maintaining solute. So more of urea is absorbed in acute renal failure. So urea might go into 80, 100, and creatinine is only 1, 1.4, 5, 6. So you will find this thing. So here you see the pre-renal azotemia, how pathophysiology we can explain. In the macula densa, it will change for the low fluid flow or low sodium concentration, and juxtaglomerular cells are secrete the renin. So kidney, this liver will also secrete angiotensin 1 enzyme. So with renin, this is converted to angiotensin 1, and ACE enzyme is being secreted from the pulmonary blood, and it will convert it to angiotensin 2. This angiotensin 2 will stimulate the adrenal cortex, and which will secrete the aldosterone to maintain the volume. This will cause what? It will retain the sodium, will not allow sodium to be excreted, and but potassium will be excreted. So aldosterone inhibitors like spironolactone, how they act? They are labeled as a potassium retaining diuretics. So they will secrete the sodium but retain the potassium. So opposite to this. So ADs will cause aquaporin to move to the collecting duct membrane, which will increase water reabsorption. So again, the hepatorenal syndrome, you should know about this disease also. So hepatorenal syndrome, when already patient is in hepatic failure, and at some certain point patient is going to renal failure. So suddenly patient coming with the सिरोसिस हो गया साहब, आज पेशाब का आउटपुट नहीं आ रहा, यू थिंक it is some problem with the kidney and you give Lasix. So patient may pass urine sometime, but at times it may not pass urine. Then we can label it as a 48 hours तक उसका urine output well maintained नहीं होता है. Then we label it as a hepatorenal syndrome. So what are the precipitating factors of HRS, hepatorenal syndrome? या तो patient infection हो गया ascites में, SBP, spontaneous bacterial peritonitis, or somebody has ordered you or you have tried to take out the large amount of fluids और उसके 15 लीटर से ज्यादा है, पेट फूल रहा उसका, बिल्कुल 20 लीटर पानी होगा, 5 निकाल लेंगे क्या हो जाएगा. But few patients may go into hepatorenal failure because sudden shifting of the fluid from any compartment may lead to secretion of certain substances and it will lead to renal failure. Aggressive diuresis, again सब सीजन तो कमी नहीं, पिछली बार भी दवाई ले गया था आपसे महीना भर पहले. So you try to give more diuretics, 40 BD से 80 मिलीग्राम BD ले लो, बट जरा सा डाययूरेसिस को ज्यादा हो गया, you may go into again into ARF, HRS. Or if there is a GI hemorrhage inside, large amount of blood is gone from through vomiting. Hepatic renal में hepatorenal failure में क्या होता है? Cirrhosis में there may be hematemesis because esophageal varices may rupture. If large amount of blood is lost at this one episode, then patient suddenly there is again decrease in the volume. Effective volume is, circulating volume is decreased. Patient will go into AKI, hepatorenal syndrome. So management again, you have to remove the precipitating causes. Look for the SBP. Most of the time you have to give antibiotic. लेबोरेटरी भेजोगे एक दिन बाद में रिपोर्ट आएगी सामने. Better you start antibiotic in these patients, taking granted of bacterial pattern. If patients large volume, don't do large volume paracentesis in these patients. Also don't give aggressively diuretics. Wait. Don't give high doses of diuretics in these patients. GI hemorrhage, if there is, immediately control it, replace the blood so that patient do not go into HRS. So management in HRS, what hepatic failure is major issue. So definitive treatment is liver transplantation, and supporting will be remove the precipitating causes just I described with all diuresis and dialysis support, because now kidney is at risk, so creatinine is rising and patient's output is very limited or nil, then patient can be supported by dialysis for the time being. So 4-5 cycle हो जाएगी तो patient may go come back from HRS. Prerenal azotemia, again heart failure. This azotemia may improve by the ventricular unloading. You are giving diuretic, give digoxin, give ACE inhibitors. So they will all help in the cardiac failure. Nowadays, glyphosins, diabetic drugs, empagliflozin, canagliflozin, and dapagliflozin. These all drugs are actually anti-diabetic drugs. They causes more of the sugar to be lost through the kidney. Okay, but simultaneously fluid is also lost. So CHF will improve patients. If patient is in CHF, his overloading is improved. So in heart failure, if we unload the ventricle, then patient's heart will pump better and patient's azotemia will improve. In hepatic failure, again the same thing. Splenic vasodilation is there and there is venous pooling. Again, this will be sensed as a decrease volume in the circulation. Just I described. So serum creatinine is more than 1.1, increased by 1.5. And if you give 2 days of diuretic therapy and still patient doesn't improve, then only we can label this as a hepatorenal syndrome. So hepatorenal syndrome के लिए पेशेंट का क्रिएटिनिन 1.5 या ज़्यादा हो और आपने डाययूरेटिक थेरेपी भी दे दी इसको, रूटीन जैसे दे रहे हो, still patients erythemia not improve, then we can label it as a hepatorenal syndrome. But you should rule out first there is no sepsis, there is no shock, there is no nephrotoxic drugs, or no pre-existing kidney disease in these patients. Then only you have to label it as hepatorenal syndrome. So NSAID, how it affects? So दोनों दवाइयाँ NSAID and ACE inhibitors. NSAID is non-steroidal anti-inflammatory drug. So it will cause what? Blocks the vasodilatory effect of the prostaglandins. So efferent artery अगर constrict हो जाए, वहाँ पे प्रोस्टाग्लैंडिन्स हैं उसको डायलेट करके रखते हैं. अगर वो आपने NSAID दी, पर्टिकुलर इन केस ऑफ वॉल्यूम डिप्लीटेड पेशेंट, एंड दिस विल कॉन्स्ट्रिक्ट द वेसल और उसके अंदर फ्लो बनेगा इन लाइक. सिमिलरली इफ इफरेंट आर्टेरियल में और एस इनहिबिटर होंगे, दे विल कॉज मोर डायलिटेशन इन द इफरेंट आर्टरी. तो पीछे ग्लोमेरुलाई आगे आपने डायलेट कर दिया उसको, देयर इज नो प्रेशर विल सडनली डिक्रीज. सो एफरेंट पे तो NSAID और इफरेंट पे एस इनहिबिटर, दोनों का फर्क अलग अलग है. वहाँ कॉन्स्ट्रिक्शन कर रहा है घुसने से पहले और यहाँ आपको ज्यादा डायलिटेशन, दोनों का प्रेशर नहीं बन रहा है ग्लोमेरुलाई में. देन पेशेंट में गोइंग टू रीनल फेलियर. Similarly, abdominal compartment syndrome we already described. Post-renal exotemia, we already described this BPH. तो प्रोस्टेट जैसे वहां से बना किडनी के पेल्विस से वहां कोई ब्लॉकेज हो गया, मल्टीपल स्टोन्स हैं बायलेटरल, और बायलेटरल यूरेटर में स्मॉल स्टोन्स हैं, फिर क्रॉनिक ऑब्स्ट्रक्शन होगा दोनों जगह से. देयर इज नो फ्री फ्लो ऑफ यूरिन. यूरिन सिंगल साइड में भी हो, क्रॉनिक 3-4 महीने चल रहा है, मॉडरेट ऑब्स्ट्रक्शन कर रहा है, तो एक किडनी काम करे, दूसरी किडनी का यूरिन बंद कर रहा है लेकिन निकल नहीं रहा है. दिस विल आल्सो लीड टू द AKI. बायलेटरल किडनी स्टोन्स, अगेन मैलिग्नेंसीज एनीवेयर इन द रूट, प्रोस्टेट की मैलिग्नेंसी, ब्लैडर नेक पे मैलिग्नेंट ट्यूमर हो गया. ओके, so they all will lead to renal cancer obstructing the pelvis hole. RCC is obstructing the pelvis, so again patient will go into renal failure. Or increased intratubular hydrostatic pressure due to any cause, the back pressure side. This will cause decreased GFR and increased creatinine level. And in these patients, USG KAB and CT KAB is helpful to delimit where is the obstruction, is there obstruction or not, and at what level it is. So according to that, we decide the therapy. So in BPH, what we see is about the post-void urine. Significant urine अगर जैसे more than 300 ml दिखता है आपको, पेशेंट को आपने बोल दिया यूरिन करके आ जाओ, दोबारा सोनोग्राफी ब्लैडर की होगी. Particularly elderly patient to see the effect of the प्रोस्टेटिक हाइपरट्रॉफी जितनी भी है, चाहे 30 ग्राम है, 40 है, 60 ग्राम है, तो उसका ऑब्स्ट्रक्शन ऐसे ही देखते हैं. पोस्ट वाइड यूरिन वी ऑर्डर फॉर दैट, एंड देन विथ मोर देन 300 ml इट इज सिग्निफिकेंट. सो इन BPH ट्रीटमेंट वी इमीडिएटली कैथेटराइज द पेशेंट फॉर few days or few weeks till the creatinine comes to normal, and advise the patient for BPH surgery, prostatectomy. Upper uretectomy obstruction हो रहा है, plan for the DJ stenting in the upper part of the ureter. और nephrostomy kidney में है तो nephrostomy. When there is relief of obstruction, the renal failure will improve and will be dry. पहले उसका यूरिन कम बाहर निकल जाता है, after relief of obstruction there will be great amount of urine will pass for 2-3 days continuously. आपने fluid तो जा रहा है 2500 cc total intake, urine out will be 4500, 5500 तक देखा हमने. It will come to that level, 8 liters तक पास कर सकता था after driving this renal of obstruction. So post obstruction renal there will be diuresis compensatory. So more amount of urine is passed, more of fluid is lost. In these cases, you have to remain alert for the electrolyte disbalance. Sodium, potassium, late in urine, you have to, particularly potassium, you have to see for that. So watch for the electrolytes in diuretic phase. Sometimes crystals, we are giving treatment for HIV, particularly the protease inhibitor like indovinavir. Our antiviral drug acyclovir for herpes zoster, we are giving HIV to this patient, herpes zoster patient ICU. And then we are going to make more of the crystals. So micro-obstructive uropathy में occur, ट्यूब्यूल्स के crystals जमा हो जाएंगे इन patients में. So they will be lead to micro-obstructive uropathy and then go into post-renal kidney failure. Intensive failure, again we have to see for the tubules, vessels as well as interstitium. Interstitium में there will be interstitial nephritis either due to allergy to the penicillin, sometimes PPI also. They will cause interstitial nephritis. So PPI is not this ultimately safe drug. We are giving 2 years, 3 years without problem, no problem, then it's no issue. But you should remain alert. At any point, if you find there is development of AKI, you can stop PPI for few days if not urgent indication. NSAIDs, as I told you, even rifampicin, infections like severe pyelonephritis. This will cause interstitial nephritis and sepsis, infiltration by lymphoma or leukemia. Inflammatory like autoimmune disorder, Sjogren's syndrome or tubular interstitial nephritis, sepsis, they all may lead to interstitial nephritis. So tubular, you all know, toxic or ischemic ATN, acute tubular necrosis, either due to ischemia, patient का hypotension है, particularly female patients during parturition, during delivery, patient हुआ shock में, suddenly 1 liter or 2 liter उसका blood loss हो गया, they replace but slowly or late only, शाम तक blood मिला, इस दौरान they may go into AKI. So similarly, small vessel, glomerular nephritis, we all know. Glomerular nephritis or vasculitis, any kind of vasculitis, autoimmune disorder again, we are TTP and HUS, thrombotic thrombocytopenic purpura, or HUS, hemolytic uremic syndrome. They all cause acute, these are causes of the acute this intensive renal failure. So tubule we have seen already, ATN is most common in ICU setting. This is due to hyperperfusion already you know. अभी एक पेशेंट ICU में है फर्स्ट में हमारे, तो she has come from आगरा, वहाँ पे ठीक हुआ, अभी अपने आवास बढ़ती है, ऐसी renal failure और उसका parturition के बाद में हुआ उसका 8th delivery I think, and that too also LSCS. She is improving, but अभी urine output उसका slow भी आएगा, धीरे आने वाला है. Any kind of hemorrhage during surgery या sepsis हो गया उसको during parturition or prolonged renal insult, this may cause tubular acute tubular necrosis. Sometimes due to the we are giving dyes for contrast dye we are giving for the study. तो patient का already creatinine बढ़ा हुआ है, 1.7 हो गया. Readily we will not give dye to these patients. Let us treat the patient first. Let her or him be stabilized. Creatinine कम हो जाए, urine outflow is good. Then only we proceed with the contrast study. So sometimes in this patient acute renal failure, FENA is more than 1%. Fractional excretion of sodium. Nowadays we are seeing in the ICU. The FENA, very common term nowadays in. So if more than 1% shows the loss of concentrating power of the kidney. So in oliviric patient, acute tubular necrosis, FENA will be more than 1% because kidney is not able to conserve sodium. Acute renal, but in pre-renal failure, kidney is okay, it is conserving sodium well. So FENA will be less than 1% in pre-renal failure. But in renal failure, acute tubular necrosis, FENA will be more than 1%. This is the calculation, how we calculate urinary sodium, and serum sodium is calculated as similarly urine creatinine as well as serum creatinine calculated by laboratory, and this is the equation: urinary sodium upon serum sodium divided by urinary creatinine upon serum creatinine and multiplied by 100. Intrinsic renal disease, how to manage it? Simply manage by fluid and electrolytes, avoid the nephrotoxic drugs. Once you see the creatinine is rising, better adjust the dose of the antibiotics, particularly piperacillin, tazobactam, even meropenem. We have safe antibiotics like ceftriaxone and ampicillin. Ampicillin not used nowadays very much. So these are safe for kidney, so you can continue in the same dose. But say piperacillin or meropenem, they are higher antibiotic. Better read the leaflet or go to the internet according to the GFR. Reduce the dose of the antibiotic. Similarly, avoid nephrotoxic drugs. किसी पेशेंट में अगर क्रिएटिनिन बढ़ रहा है, better stop gentamicin or streptomycin if she is getting, and other nephrotoxic drugs should be avoided. हाइपोवोलेमिया हो गया उसको, गिव IV fluids. अगर कार्डियक फेल हो रहा है, फ्लूइड ओवरलोड है, challenge diuretic dose. 1 to 3 ml of Lasix per day you can give. So recovery from ATM, it will typically take 1 week to 6 weeks. Not hard and fast, but 1 to 6 weeks. It may take 3 months, but usually the range is 1 to 6 weeks. And if you manage well, 85% will become okay, acute renal failure patients. HUS-TTP similarly, hemolytic uremic syndrome with thrombotic thrombocytopenic purpura. So this is a disease you should remember that there is some disease like that. So patient का anemia हो रहा है and there is hemolysis, bilirubin भी बढ़ रहा है उसका, और patient shock में चला गया, विदेश में गया, renal failure में गया. Remember this, both HUS and TTP. The patient may come with the diarrhea, particularly children and young adults, they will come with the history of diarrhea and there is fever, and they may go into altered state. Kidney function is gone. The patient will altered condition में आ सकता है, altered mentation में. Remember this thing that this may be the cause. Complement level, renal tubule toxic. As I described this, apart from contrast, there are pigment uropathy also. Pigment which one? Hemoglobin and myoglobin. From where? Hemolysis हो गया खूब सारा, तो hemoglobin नहीं हो गया इसमें, अंदर उसके through hemoglobin is circulating in the blood and it will go to kidney, it may block the tubules. Similarly, myoglobin from severe muscular trauma, RTA उसके काफी क्रश इंजरी हो गई, पेशेंट भी ओके, बीपी उसका ठीक है, लेकिन उसके इतनी क्रश इंजरी हो गई, सारा मायोग्लोबिन उसका बाहर आ गया, जो रप्चर्ड है उसकी मसल्स है, and it may be absorbed and again go to kidney and it may block the tubule. It can cause myoglobin urea also. So we should remember these conditions, that this also may be the cause of the acute renal failure. We already discussed iodinated contrast. Prevention for these is do good hydration, don't give diuretics in these patients, and soda bicarb infusion should be started. If you suspect kidney function is worsening, creatinine बढ़ रहा है उसका, start soda bicarb for 1 hour 150 ml per hour, उसका 3 एमपीएल डाल करके 1 NS में डाल के इसको शो कर सकते. So first hour 150 ml per hour, then 50 ml per hour for 6 hours. This already we discussed about the contrast. Renal tubule, again aminoglycoside I told you. Another cisplatin pigment nephropathy described, rhabdomyolysis we already described it. So this is about all about our topic today. Interstitial we already described. Treatment again for renal failure, acute renal failure. If there is hyperkalemia, potassium, exogenous potassium in a therapy should be stopped. अगर आप कीसोल दे रहे हैं due to some reason, it should be stopped and K-bind sachets, there's potassium binding sachet available. Start orally, or sometimes we have to go for dialysis. And for urgent hyperkalemia हो गया 6.5, 7.5 आ गया. 7.5 means you should go for dialysis. 6.5 दिख जाए, immediately start calcium gluconate 6 hourly 10 ml and insulin glucose infusion immediately. What it will do? It will make the potassium go into the cell, so it will not remain in the serum, so it will not go to the heart tissue, so it will save the heart tissue from hyperkalemia. So dialysis medication we last time we also discussed. So any patient come to you with the acute renal failure or chronic renal failure, these are few certain indications, 5-6-7 indication होते हैं. Immediately you should be alert. If patient का potassium very high, more than 6, but practically after 7.5 you have to order for dialysis. Acidosis हो गया उसके 7.2 से low है उसका pH. Again due to kidney disease only. Then it's indication for, and even for poisoning, sulfose poisoning. What is causes? It will cause acidosis. Patient is okay till 1 hour before death. So they don't know anything. Patient is okay. You are giving infusion now और सब कुछ नहीं है इसके, तो sulfose खाइए कोई दिक्कत नहीं, ठीक हो जाएगा. It is not that. It will cause suddenly metabolic acidosis. BP will go. 5 मिनट पहले आपने 110 BP देखा, 5 मिनट बाद में आपको 60 मिलीमीटर देखेगा mercury, and there is no saving of the patient. So if urgent hemodialysis you can do it, patient may be saved. Patient may be saved. As there is daily rise of blood urea more than 30 milligram or more than 300 हो गया इसका, then dialysis of benefit. Dialysis should be done. Creatinine level more than 7 milligram % हो, या pulmonary edema which is not responding to the diuresis. Pulmonary edema due to kidney failure. So pericardial disease, आपने कोई भी आपने एग्जामिन किया pericardial रब आ रही है उसके, patient is in renal failure, immediately indication for dialysis. Again उसके अगर cardiac temporal heart में उसके fluid भर गया and large size kidney failure, it is an indication for the dialysis. Again encephalopathy, I think if patient goes into uremic encephalopathy and you find the urea creatinine very high, immediately go for dialysis. So these are indications for dialysis. I think this is enough for today.